So I think it'll be a quick refresher course for most of you. So should I start? Can somebody just type in a message if it's okay? I don't seem to be able to hear anybody. Okay, so good evening, everybody, and it's once again a real pleasure to be amongst all of you. I wish it was time for physical meetings, and I'm sure in the near future we will start having physical meetings as well. But till such time, we have to make do with the Zoom meetings. Once again, I'm here to discuss with you some practical interpretations of renal scans, especially with the diuretic renal scans, the DMSA scans, the transplant evaluations. Most of my presentation are images, so just sit back, and these are the kind of images which you may get as spotters during your exam. So and also in your practice, you should know how to interpret and look at the renal scans. So that's the whole aim. It's a practical interpretation of renal scans for nephrologists. So if you quickly go through the radiopharmaceuticals which you use, so we start with diuretic renal scintigraphy. So we have agents like DTPA, MAG3, EC, which is LLEC, DMSA, and GHA. Now, out of this, DTPA is what is most commonly used, and it is a pure glomerular filtration agent. The problem with DTPA is that there is only 20% first pass extraction. So there is the image quality can be improved as compared to MAG3, which is again the mode of excretion is tubular secretion, and it has got an first pass extraction of 50% as compared to the 20% of the DTPA. Technetium EC, which is actually an indigenous product and used at most centers now, especially amongst the children, where we are trying to image the pediatric population, has got a much higher excretion, and it is a molecule which is similar in behavior to MAG3. So this is also excreted by tubular secretion. And important is that when you get tubular secretion agents, when you're dealing with tubular secretion agents, you don't get GFR, you get something called effective renal plasma flow, which is actually the same thing. It's just that the value which you get is ERPF. Then you have the cortical agents, which look at the cortical structure, which look at the morphology, mainly used for looking at scars, cortical scars. And there are two agents, one is DMSA and GHA. Now these agents are very strongly protein bound, so they get attached to the cortical proteins. So DMSA is attached by the megalin-cubulin receptor endocytosis in the proximal tubular proteins. And because these are so highly protein bound, they take time. It takes about 3 hours after injection before we can actually scan these patients. But you get excellent morphological details. And it does not just give you morphological details, it also gives you functional details, in the sense that the wherever there is any edema in the tubules, or there is any dysfunction because of infection or because of any mass, there you will see a defect on a DMSA. So and this may revert back to normal once the cause for the edema actually settles. So that's how you can although it looks like just a morphological scan like an ultrasound or a CT, this actually gives you a anatometabolic kind of an imaging of the kidney, right? And then you have GHA, which used to be used more commonly about 20 years back. And the advantage of GHA was that it was only about 20 to 30% protein bound, and the rest of it would be excreted by glomerular filtration. So you would get some degree of glomerular, so you could do a dynamic study with GHA to look at the glomerular function and look at the the delayed image to look at the morphology. Now, while this sounds very good theoretically, practically what you had was a suboptimal glomerular agent and a suboptimal cortical agent, and hence now today GHA is seldom used for renal imaging. Now coming to diuretic renogram. If you look at the preparation which the patient has to have, the patient should be well hydrated. And especially in those cases, since most of you are nephrologists, would be dealing with renal donors, it is important that to get an optimum GFR, you should give the patient an additional oral fluid load of 5 to 10 ml per kg of body weight 30 to 60 minutes prior to the scan. So this is very important. If you have a patient who's dehydrated, both the renogram pattern as well as the GFR would be reduced. There's no special diet. Patient should not do a DTPA scan or a renal diuretic study on a day when he is fasting because of any other procedure, or diuretics should be withheld on the morning of the study. One, because it changes the renogram pattern. Two, because we anyways give a diuretic during the study. Pregnancy is a contraindication because the radiation exposure to unborn fetus is not acceptable, and breastfeeding, again, interruption of breastfeeding is not required, and all the mother has to do is to feed the baby prior to the scan, and then in the 2 to 3 hours, which ensures till the next feed, the radiation level is barely anything, and it is far less than what is the recommended radiation exposure to a fetus. And this DTPA or DMSA or any of these renal agents are not excreted in breast milk. The radiation exposure to the fetus is because of the proximity. Now this is a gamma camera. These are, most of them are SPECT images, which allow both tomographic images as well as planar images. So the camera in the case of most renal imaging is placed below the patient, right? And here you can see a little baby who can be placed directly on the head of the camera, and that gives very high resolution. And here you can see that the scan is being done with the patient lying comfortably and with the patient's the camera below the patient. Now this is the kind of a renogram curve that you would get when you order a DTPA. So this gives you some images. The first round of images is the perfusion images. So we take rapid dynamic images while we are injecting the tracer. So we've injected the tracer and started taking rapid dynamic images. These images are taken usually at the rate of 2 seconds per frame, and they are taken for the first 1 minute. And these images actually tell you you can see the arrival. You can see this is the tracer goes into the heart, the lungs, the aorta. Then it goes in through the renal arteries into the renal parenchyma. And normally within the first 3 to 4 frames, you should be able to visualize the kidney. If the visualization is delayed, or if there is any difference in the degree of visualization of either kidney, then that is a cause for concern, and we must look for any abnormal, either a renovascular pathology, either a macroscopic or a microscopic renovascular pathology, which is causing this delay in the renal function, renal perfusion. The second round of images is your dynamic cortical phase. So this starts from about 1 minute of injection of the tracer. These are dynamic images. So you place the patient on the table, you insert the cannula, you inject the DTPA, and you start taking sequential dynamic images. The cortical phase images are acquired at 1 minute per frame. So each of these images are taken at for a duration of 1 minute, and then they are kind of fused, and you get these images which show you 1 minute per frame. And these show the transit of the tracer in the renal parenchyma, going into the renal pelvis, getting excreted into the urinary bladder. And you create what is called as a renogram curve, which is nothing but a graphical representation of the transit of the tracer through the renal cortex and the renal pelvis, and shows that how it is taken up and then excreted during the course of the study. Now, Frusemide intervention, it's called a diuretic renal study. So you do give a diuretic, and usually Frusemide is the preferred diuretic because of its rapid onset of action. There may be different protocols. It may be given F minus 4. F is the point at which the study is started by the injection of DTPA or MAG3 or EC, whatever. So this F is the 0.0. So it may be given F minus 15, which means 15 minutes prior to the injection of the radio tracer, F0, which means along with the radio tracer, after 10 minutes of the radio tracer, 15 minutes after injection of the radio tracer, 30 minutes, which is basically at the end of the initial dynamic study. Then there is one which says that there is a visualization. So somebody who is actually monitoring the study actually sees tracer arrival in the pelvis and then subsequently injects the diuretic. Now, normally the current standard of care is F plus 10 in a 30-minute study, and this basically shows that it is not possible to standardize a study whereby you say that, okay, at visualization of pelvis or whatever, F minus 15 or F0 is done where you have a large capacious pelvis. So in a patient who's had say a pyeloplasty, or that the patient has a big dilated pelvis, in pediatrics, in antenatally diagnosed hydronephrosis. So in those cases, you may sometimes administer the diuretic 15 minutes prior to injection of the radio tracer, just to decompress the dilated pelvis so that there is no back pressure changes because of the dilated renal pelvis. And the F0 is when you inject it. So normally in a child where you've trying to do minimum intervention, the child is sleeping, you want to inject all the tracer together, because every time you inject, the child's going to wake up. So you give an F0, which basically starts you give the diuretic as well as the radio tracer at the start of the study. Now, the rationale of these various protocols is, and of standardizing it to F plus 10 in a 30-minute study plus a post-micturating image. This is usually the standard of care at most centers across the world. The rationale of this is that it does not change the differential renal function as the F minus 15 protocol will sometimes do. It does not fill up the bladder too soon to impact the subrenal clearance, allows 20 minutes of imaging to assess the entire response of Frusemide, and post-micturition images ameliorates the effect of full bladder and assists the gravity-assisted drainage, assessment of the gravity-assisted drainage. Now, as I said before, in the pediatric age group, sometimes we use the F0 protocol simply for operational advantage. Now, the dose of Frusemide may be 20 milligram, 40 milligram, 80 milligram. When we were students, we used to give higher doses of 80 milligram, but now the current standard of care is 20 milligram of Lasix with 400 ml of oral fluid at the start of the study. So if the patient is well hydrated with 400 ml of oral bolus, you can give 20 milligram, and this gives you a most standardized report. The rationale is that by giving higher doses of Frusemide, you actually create hypotension, which changes the dynamics of the renal parenchymal transit and the renogram curve. So a 20 milligram with a 400 ml oral fluid is what is the standard of care today. Now, the second thing is drawing a region of interest. So whenever we talk about seeing the transit of tracer through the renal parenchyma, we draw what is called as a region of interest. So we draw an outline around the kidney. Now, there have been a lot of talk about whether the outline of the kidney should include the entire kidney or whether it should include only the cortex. Now, it has been seen that when you draw these ROIs, there is very little inter-observer differences in drawing ROI, and the recommended ROI should include the whole kidney, which includes the cortex as well as the pelvis. So that gives you the best kind of a renogram pattern, most comprehensible renogram pattern. Now, if we split up the renogram curve into parts, so it has three phases. The first phase is the vascular phase, which usually lasts for about 1 minute. So this is the rapid filling phase, which we had talked about. Then you have the equilibrium phase, which is also called, which is actually the transit of the renal agent through the renal cortex. And then from about 5, so this, the peak uptake usually happens around 5 minutes, 5 to 8 minutes. And then it is at this point that the tracer starts to clear, which is the clearance phase. And the T half max, a value which everybody is very obsessed about, is the time for the activity in the kidney to decrease to 50% of its maximum value. So if you have a maximum here and you have a 50% value here, so something which this time is called the T half max. So the time it takes for 50% of the tracer to be cleared from the kidney. So the 50% of the maximum tracer, that is the T half max. Now, if you look at the actually what each of these components will express. So the initial is, of course, the uptake. This is the time when the activity is increasing, and the elimination starts from the time that the renogram pattern comes, where you see a downslope in the renogram pattern, and the rate of elimination is greater than the rate of uptake. So it is not exactly, there is an overlap, and it is a continuous process. It is not that, it is not in quanta that it just takes up and then put from here. So, but at this point somewhere, you start seeing a downslope when the rate of elimination is greater than the rate of uptake. And this shows the duration by which it takes from peak max to 50% max is the renal parenchymal transit. Now, these curves are called O'Reilly's curves, right? And on the basis of these O'Reilly's curves, you actually decide whether a patient has got obstructive uropathy or not. So if you look at these curves, these are the type 1 curve is a normal curve where there is a peak activity at between 3 to 5 minutes, and then there is a rapid excretion phase. And by the end of the study, by 30 minutes, there is less than 30% of the peak activity left in the kidney. So this is a normal curve. The type 2 curve is a typical obstructed curve where you see the peak and then the filling phase continues, and this is because of a dilated pelvis or because of any outflow obstruction. Type 3A is a hypotonic kidney. So this happens when you have a large capacious pelvis where you can once you give the diuretic, because there is decompression of the dilated pelvis, there is a rapid excretion which happens. Type 3B is an equivocal. So this happens in partially obstructed systems, or sometimes you will also see in where you have a post-pyeloplasty system where sometimes you will see this even in very dilated pelvic calyceal system where the slope is downgoing, but the patient does not achieve the less than 30% landmark by the end of the study. So the renal parenchymal transit is a little prolonged. So there is a delayed arrival of tracer into the pelvis, and the response to the diuretic is also blunted. So this is the type 3B or the equivocal kind of a study. And you have the type 4, which is called the delayed compensation, whereby you see that there is initially on Lasix, there is a drop, but then subsequently there is a filling again. So this happens when there is a high grade obstruction. So there may be a little response to Lasix, but then the kidney starts filling up again. Now, there are pitfalls to these renogram curves. One of the most common pitfalls is, as I mentioned before, a capacious pelvis, where you have a large pelvis where the radiotracer keeps filling in. And because of that, there may be a change in the renogram pattern, and this is called the reservoir effect. And so it is important to keep the pelvis decompressed, so which can happen either by administering the Lasix 15 minutes prior, at least asking the patient to void prior to the actual imaging. And in a child, sometimes we would place a catheter in the urinary bladder to keep the bladder decompressed, so that there is the effects of the reservoir effect are mitigated. Again, the same thing, where you see a full bladder, you have a patient, you can see the DTP in the delayed image. You can see that there is, in the initial dynamic phase, there is the tracer accumulation in the pelvis, and you see the bladder is full here. Once the patient voids, the radio tracer, which was showing some stasis in the upper calyces, also clears. So once this bladder gets decompressed, the reservoir effect goes away. So again, T half max, there are different values which are normal depending on the tracer which is used. Since MAG3 and LLEC are excreted more rapidly, the T half max, normal T half max, is about 12 minutes, whereas in DTPA, where the tracer and the excretion is slower, the normal T half max is about 15 to 17 minutes. So traditionally, T half max more than 20 minutes was considered obstruction. However, it is important to remember that there are a lot of variables, so you cannot really just report and go by one value, which is the T half max. There are many alternative quantitative parameters which have been used, which include post-void to max ratio, 20-minute to maximum ratio, tissue tracer transit time, P, which is pelvic excretion efficiency, output efficiency, and NORA, which is basically the renal activity at a given moment, which may be either the end of the renogram or the end of Frusemide intervention and a later image after micturition, divided by the renal activity at 2 minutes. Now, these are basically looking at the same aspect. If you just remember a thumb rule, 30% of your peak activity count should be not more than 30% of your peak activity count should be retained in the renal system at 20 minutes post-injection. So this is what you need to remember. All these are basically looking at the same thing and looking at it from trying to quantify it from different aspects. But as a rule of thumb, less than 30% should be retained in the kidney at 20 minutes of injection of the radio tracer. Now, the common indications of diuretic renal scintigraphy are, of course, the most common is suspected PUJ obstruction, where you have post-urethral reimplantations because of megaureter or because of obstructive PUJ obstruction, prune belly syndrome, horseshoe kidneys, polycystic kidneys, ectopic kidneys, renal transplant obstructions, prior to nephrectomy to assess the contralateral kidney, the ileal loop diversions, and obstructive masses in the pelvis. So I think we're going to go into the radiation exposure. So the radiation exposure is very minimal. So it is 0.04 plus minus 0.03 megabecquerels, milligray per megabecquerel for the kidney. So typically about 12 to 24 megabecquerel is injected for doing a scan. So you can see that the amount of radiation exposure in a DTPA is very, very minimal, and the excess lifetime risk for the development of radiation-induced cancer, if you do a DTPA scan in newborns, is 16.8 per unit 10, 100, 1,000, 10,000 lakh. So 16.8 per lakh persons, whereas if a child is slightly older, it reduces to about 14.7 per 100,000 persons. And the radiation exposure of other modalities, if you compare that, so the mean effective dose is about 0.02 millisieverts per megabecquerel, and if you compare that with an IVP or a CT, it is far more. So these are there should not be any worry about radiation exposure. These are actually very safe and safer than most of the other radiological imaging. There have been a lot of questions about whether do we really need diuretic renography, and slowly I think people are moving on to CT urography or MR urography in patients with, especially in adults, where the cause of obstructive uropathy is usually due to a lower pole crossing vessel or an aberrant vessel or a renal calculus where or a renal mass. All of these can be seen better on a CT or a MR urography, and hence the role of a diuretic renography is basically to assess any functional impairment or in equivocal clinical scenarios to decide clinical management. So coming to the images, this is an obstructive hydroureteronephrosis, whereby you see that the renal, there is a thinning of the renal cortex, there is a photon deficient area in the medially in the region of the pelvis, and which slowly fills up with time. And you can see the renogram pattern. You see this is the normal side, which is the left side. Now in a diuretic renogram, the left is left, your left is the patient's left, your right is the patient's right. So this is the left and this is the right. So this is different from CT, where you kind of cross your hands and you have the right is it's opposite to your own sides. And here, so this is the left kidney, this is the right kidney. So the right kidney is the one which is hydronephrotic and obstructed, and you can see the same thing on a upgoing renogram curve. Now, one of the problems which sometimes you may have is in patients who've got a fairly functioning kidney or a not very poor functioning kidney, and you have a large capacious pelvis, and often the differential renal function in the affected kidney is demonstrated as more than 55% of the total renal function, and where a normal function is between 45 to 55%. This happens more commonly in pediatrics, and often such patients, once they undergo a pyeloplasty, once the kidney, the pelvic size becomes normal, their differential renal function normalizes. But this causes a lot of concern amongst the parents who feel that pehle to 55% tha, डॉक्टर साहब आपने ऑपरेशन किया and it comes down to 45%. So they feel that there's something wrong. So it's important to see this and understand this fact that this is simply it's a fallacy of the system, whereby the geometrical configuration of the kidney actually causes a falsely high differential renal function, and it alters the detection of the scintillations, and it overestimates function. So whenever you have a functioning kidney with a huge dilated pelvic calyceal system, it's important to remember that the differential renal function may be overestimated in these kind of situations. Okay, so this is a grossly hydronephrotic kidney. So you can see the pelvis is grossly thinned out. You have a large pelvis, and the cortex is thinned out. You can just see a thin rim of cortex. This is a normal kidney. And you can see the normal kidney, you have the tracer which arrives in the pelvis and then gets cleared out. Whereas here, slowly, there is a renal parenchymal arrival into the pelvis, and which is retained even in the delayed images. And you can see that the renogram curve here is not just upgoing, the peak activity is much less than the normal side. And you get a differential, all these numbers which tell you what is the differential functions. You see it is 60-40 differential contributory function, as well as it tells you the time to half and the T half max. Okay, so this is a renal cyst. This I just put up just for this. So it's important not to confuse renal SOLs with dilated pelvic calyceal systems. The renal cysts, renal masses would often be more lateral, whereas the pelvis is more medial. So there is a lot of imagination which happens in renal imaging. So you have to really visualize what you're trying to see. But the thumb rule is that the pelvis is medial and most of the SOLs are laterally. Okay, so this is a very interesting study. This is a duplex moiety. So if you remember, the in a duplex moiety, the upper system is usually obstructed and the lower system is shows reflux. So the upper pole, you can see that there is it is hydronephrotic, and you can see that there is a photon deficient area. The lower moiety is actually showing good uptake and showing a good excretion. The upper moiety, being hydronephrotic, shows delayed arrival of tracer in the pelvic ileal system, and in the upper pelvis, the tracer is retained even in the post-void image, and you can actually begin to see the ureter here and in the delayed image. So this is again a system where you have a duplex moiety and the dilated hydronephrotic upper moiety, and this is the Wiegert-Meyer's rule. So just for it's an interesting study. And you can actually fool the system by drawing ROIs across both the moieties and seeing the differential pattern of excretion. And here an ROI, we fool the system into believing that the left kidney is actually the upper moiety and the lower moiety is the right kidney. And you can see that the lower moiety shows good excretion, whereas the upper moiety shows an obstructive pattern. Okay, so more of the same. Now, this is a typical cobra head appearance. This is a uretrocele, and this is an obstructive kidney because of the uretrocele, which you see at the just low at the lower end of the ureter. So this is called a cobra head appearance. It looks like the head of a cobra, and this often the uretrocele shows detention of tracer even in the post-void images, and you can see that here. Now, this is a patient who was detected with who came to us with left hydroureteronephrosis. You can see this is a small child, and you find that the left ureter is dilated. In fact, both the ureters are visualized, but the left ureter is dilated. And at 2 hours, you find that there is tracer which is retained in both the renal cortex, in both the kidneys, and the renogram shows a kind of a equivocal kind of a pattern. And this is a patient who had bilateral psychoureteric reflux, and you can see that there is the DMSA scar. The scan showed scarring in both the kidneys, more on the left side than the right. So this was a patient who has got a refluxing kidney, and you can, this is the same patient. This patient, since he did not undergo any treatment, over a period of time, this kidney became shrunken and is now a non-functioning kidney. So in a child, it is important to ensure that the bladder is decompressed so that there is no chance of a reflux in this kidney. Okay. So this is the 18 months later, this DMSA scan showing the same thing. Again, in an uncorrected psychoureteric reflux, you can use a DMSA to assess the progressive functional deterioration or organization of the scarring in the on a DMSA scan. So we'll come to the DMSA scan after this. So this is just another interesting case where the patient had an ileal conduit, and you can see that the as is very commonly seen, the one of the kidneys has become a little hydronephrotic. The other kidney is normal. The left kidney is normal. Right kidney has become a little hydronephrotic, and you can see both the ureters which have been attached to the ileal conduit, and the ileal conduit is showing good excretion through the ureterostomy. This is a patient who, again, another interesting case. You can see this blob of activity, which is in fact above the kidney. This was a patient who had a post-PCN urinothorax. So he had a percutaneous nephrostomy which leaked, and the tracer actually went into the thorax because of a rent in the diaphragm. And this was after the repair. So they you can see that this urinothorax, which was seen earlier, is now no longer visualized. Again, an interesting case which you cannot, this looks like an ileal conduit, but this was actually a ureteroileal fistula, which had happened because of a patient who had had a surgical trauma. And you can see that the DTPA is going into the intestines. So again, this is a ureteroileal fistula. Now, how do you differentiate whether this is a conduit or a ureteroileal fistula? Normally in a conduit, you would see both the ureters going into the intestine, whereas here you find that this kidney, the ureter, is not visualized, and it is only the right kidney which shows a communication with the intestinal activity, the typical kind of, the guidiform kind of an uptake which you see, which is basically the tracer in the intestinal tract. Yeah, so this is a zoomed picture of the same. Vesico-ureteric junction VUJ obstruction pre and post. Again, you can see that it clears from the kidney, but it is retained in the dilated capacious ureter. And post surgical reimplantation, you find that the ureter, although it is dilated, it does not retain the tracer, and in delayed images, the tracer is excreted from the renal pelvis as well as the dilated ureter. So to summarize, diuretic renography is a safe, convenient, easy to perform, a low radiation exposure. It's an excellent functional assessment, but you must ensure that the patient does not have any confounding factors like dehydration, exposure to iodinated contrast, or extravasation of tracer. Bladder should be decompressed during the study, and we should look at all the images, look at the values, and not just at Tmax, and it can be complementary to many CT diagnostic studies. So quickly, we'll go through the transplant evaluation. Should you want me to continue or stop? You can tell me on the message. Somebody please direct message me. If I don't get a message, then I'll continue. So I don't see a message, so I'm going to continue anyways. The transplant evaluation, again, it used to be very common when I was a resident. We used to get a lot of transplant evaluations for on DTPA, but now with the pathologists becoming more adept at reading transplant pathology and being able to differentiate between acute rejection and ATN, the transplant evaluations are very seldom done on DTPA nowadays. But just to complete the picture, so this is what a normal transplant looks like. So you have the kidney in the right iliac fossa or the left iliac fossa, whatever it is, and it is lower down, and it is much better visualized because obviously it is placed anteriorly, and so these images are acquired with the gamma camera placed anterior to the patient, right? And you can see that a single kidney which is placed lower down, you can see the iliac vessels, and you see the kidney which is here. So this is what a normal DTPA for renal transplant looks like. Ideally, you should do a MAG3 or an EC in these kind of cases because the extraction is better and there is a rapid excretion of the tracer, and you get a very nice curve with this, and you can actually assess the function. Also, in most cases nowadays, a renal transplant evaluation to look for a DTPA is done in a renal transplant where a leak is suspected. And in those cases also, it is important to have a tracer which is rapidly excreted so that you can actually see the site of leak. So the standard teaching is that in case of a allograft rejection, it is the perfusion which is the first thing which gets altered. So you have a reduced and a delayed perfusion, which you see now. This perfusion delay is not because of anything else, but because of the edema which happens in the kidney and in the renal vessels, which causes the perfusion to be delayed and reduced, and then subsequently the function also gets deteriorated as the degree of rejection increases. So the first thing which you see is a reduced and delayed perfusion, and you may see a delayed renal parenchymal transit. So you see that the pelvis comes much later. So because again of tubular edema, there is a delayed excretion of the tracer. You may see background activity. So these are the kind of things which you would see on a rejection. In between an acute rejection and a chronic rejection. So acute rejection, usually it is the perfusion which shows reduction, whereas the cortical function is fairly preserved. Whereas in a chronic rejection, both the perfusion and the cortical function are deranged. So again, another patient who's got a very poor functioning kidney with a leak, and you can see that there is there's extravasation of tracer in the pelvis outside extraluminal tracer, which is so you see initially a photon deficient area, which later on fills up. So this is basically a collection where the DTPA is slowly filling up. So this is a leak from the from the site of the neocystostomy. Now, to look for reflux, we have something called, there are two studies. One is an indirect radionuclide cystourethropography, which is nothing but at the end of a DTPA scan or a MAG3 study where the bladder is filled with radiotracer. You ask the patient to void in front of the gamma camera while you take sequential images, and this shows you whether there is any gross vesico-ureteric reflux or not. The other, and which is more sensitive, is a direct radionuclide cystourethropography. And why it is called direct? Because we inject the radiotracer directly into the urinary bladder, either by a suprapubic injection or by urinary catheterization. And then we ask the patient to void, and we see the transit of tracer accordingly. And here you can see that we've injected the tracer into the bladder and the child is voiding, the patient is voiding, and you find that on the left side, again, these are images which are acquired from the back. So left is left, right is right. And left side, you find that the tracer goes right up to the renal pelvis. The ureter is dilated. So this is grade 3, grade 4 reflux. And scintigraphically, we have only 3 grades, which is called mild, moderate, severe. Mild is if the tracer is only in the lower end of the ureter, that is mild. Moderate is if you can see the pelvic ileal system, and severe is if the entire system looks dilated. So that's the mild, moderate, severe. The mild usually corresponds to grade 1 vesico-ureteric reflux, which you see on MCU. Grade 2 to 3 is what you see on moderate reflux, and grade 3 to 4 reflux on MCU corresponds to the severe vesico-ureteric reflux, which you see on a DRCG. So just to bring a parallel between the two studies. So this is again another patient who's got bilateral vesico-ureteric reflux. So in these kind of situations, sometimes my residents used to ask me, how do you differentiate whether the ureter is coming from the, whether the tracer is coming from the kidney into the bladder or from the bladder into the kidney. So what you have to see is what is emptying. Is it the kidney which is emptying or the bladder which is emptying? So here you can see it's the bladder which is emptying. So since the bladder which is emptying, so this is obviously a voiding study, and you can see that the tracer is there in both the pelvic ileal systems. Now coming to the last bit is the DMSA scan. As I said before, DMSA is used for looking at cortical structure, and since it is highly plasma bound, you have to give it 3 hours for the uptake to happen, and you take images at in different projections. And what is important is to know what is the pattern in a DMSA. So normally, even in a column of Burton, you will see a normal DMSA uptake, whereas in a renal mass or a renal cyst or a renal scar, there would be absent uptake. So it is not just morphology, but also the metabolism of the renal tissue, which is important. And tumors, cysts, scars will all appear as fold defects. Acute pyelonephritis will show as a cortical defect with a maintained cortical contour, and organized scars will show as flattening of the cortical contour. So you can get the relative size, shape, position, function, and you can look for any polycystic or multicystic kidneys and look for anatomical anomalies, so like which include renal agenesis, renal ectopia, horseshoe kidney, and fused renal ectopia. So this is again the same thing. The central collecting system and medullary regions are usually photon deficient because it is the tubular proteins where actually the DMSA gets attached. So this is what a normal DMSA scan looks like. In the olden days, we used to have pinhole cameras, which would give us excellent resolution of DMSA scan. Now nobody has these cameras anymore, and you can actually on a normal regular gamma camera, you can see the cortical uptakes. You can see both of them looking like kidney beans. Any defect? So this is again a defect which you see. So this was a patient with a right pyelonephritis, and you can see that there is volume loss, and there is a cortical defect in the upper pole. And 1 year later, you find that the defect has become more organized and more sharply defined. So if you look at the previous one, it was a more infiltrative, irregular kind of a lesion. So this was a patient with an acute pyelonephritis, whereas here, after 1 year, the cortical defect has become more organized, and you see more sharper lines here. And to some extent, there you can see the cortical contour being maintained at the upper pole. So this is the same patient who had a reflux, and this was a patient with an acute pyelonephritis. So these are hydronephrotic or multicystic kidneys. You cannot differentiate between the two, especially because the cysts seem to be more medial. But considering that the kind of patchy kind of a defect which you see on this, it's most likely to be multicystic kidney. But again, ultrasound is probably a more better agent, or a MR or CT urography to differentiate between hydronephrosis and multicystic kidneys. The same thing, bilateral poor functioning kidneys. So if the kidneys are not functioning, the tubular proteins will not show binding, and then they will you will see the tracer all over the place. So you will see it in the liver, you will see it in the heart, you will see it in the blood pool activity, but you would not see it in the kidneys. So here, this you can see this patient has got two small shrunken kidneys, and because the patient's renal function is poor, so there is barely any uptake in the renal cortex. Okay, this is a DTP. Okay, sorry, this was a patient where an iodinated contrast had been administered, and on the first day you can see that the DMSA shows, there's a lot of background activity, and you can see the tracer in the heart, in the liver, everywhere. And the same patient underwent a DTPA on day 7, and you find that the effect has disappeared. So it's very important that there is no iodinated contrast or any nephrotoxic substance which is given to the patient. This becomes very important, especially in patients who are undergoing donor evaluation. So they have to have a CT angiography and a DTPA scan. So it's important to schedule it like that. So you have the DTPA first and then have the CT angiography, so that your exposure to contrast happens after the DTPA scan, right? So this is again DMSA with a poor radiopharmaceutical preparation. So sometimes if the DMSA does not, is not a good quality DMSA, you will get all kinds of activity in the bowel, in the liver, in the heart. So again, it's important more for the nuclear medicine physician to know that the radiopharmaceutical quality is good. All right. These are horseshoe kidneys. These are just put up for interest. You can see that both the moieties, and you can see the functioning band which is joining these. So these are spotters which you may see during your vivas. So ptotic kidney, again, this is a low-lying kidney which is seen on a DTPA. You can see that normally both the kidneys would be at the same level. Here we have one kidney which is lower down. Ectopic low-lying kidney, and here you find it is ectopically placed, and with the the pelvis facing laterally as compared to a normal kidney, which is where the pelvis is facing medially. So these are ectopic kidneys, which you can see on a DMSA scan. So various ectopic kidneys and seen on different projections. Cross-fuse ectopia, where you see, whenever you see that an empty fossa, you must look for the renal, the kidney either on the contralateral side or sitting in the pelvis. So here, this was a patient with a cross-fused ectopia, and you can see that, you know, this kidney, while it cannot really very well appreciate here, but in a DMSA scan, you can see these are the two kidneys. So this is one kidney, this is the other kidney. And if we have the pinhole view, or you have a high resolution view, you can actually define the two kidneys very nicely. And this is a cross-fused ectopia, again a spotter case, which you can see. And you can take a tomographic image on a DMSA and do a DMSA SPECT and see the various components of the two kidneys. These are variations of kidney shape on DMSA. You can have a pancake kidney, you can have kidneys which are facing outwards, you can have cross-fused ectopia, you can have both kidneys which are ectopically placed, and you can have cross-fused ectopia whereby one kidney is facing medially and the other facing laterally. So these are various variations in ectopic kidneys. Pancake kidney, where both the kidneys are fused, and you cannot really differentiate the various components of the different kidneys. So this is a DMSA scan where you can see you cannot differentiate between the pelvic calyceal system and the cortex of either kidney. Just last two slides on ACE inhibitors. So ACE inhibition renography is used to look for renovascular pathology. The indication is severe hypertension or resistant to treatment, abrupt or renal or recent onset of hypertension under the age of 30 years or over 55 years, abdominal or flank bruit, and worsening renal parameters after ACE inhibitor treatment. Now, this used to be more commonly used earlier on, where, you know, when we did not have such good modalities of MR angiographies. But the advantage of using ACE inhibitor renography is it does not just look at macrovascular or large vessel renovascular pathology, but it also looks at small vessel renovascular pathology, and it often helps the clinician to guide whether this patient should be placed on an ACE inhibitor or not. And the sensitivity for detection of renovascular pathology it depends on what the degree of stenosis which is there, and more importantly, it has got a predictive value to look for the clinical improvement in hypertension after revascularization. So if you find a patient who demonstrates renovascular pathology on a ACE inhibitor scintigraphy and you revascularize this patient, there is a higher chance that you would be able to predict pre-operative, pre-angioplasty, whether or not this patient would improve in terms of his hypertension after revascularization. So this is a patient with a high probability scan, and you can see that this is had a unilateral bruit which was seen on the left side, and this is the baseline study and the baseline renogram curve, and post radionuclide post ACE inhibitor, you find that the uptake has reduced as well as the renogram pattern has changed. So it has become a very flat renogram curve. So the interpreting criteria are worsening of the curve, reduction in the relative uptake, prolongation of the renal parenchymal transit time, increase in the 20-minute to peak ratio, and a prolongation of T half max. So it basically shows that there is a worsening of the renal function, and that can be seen on all this. And depending on the on these criteria, you actually show whether it's a high probability or a low probability for a renovascular pathology. Intermediate probability, especially in situations where you have a small poor functioning kidney or kidneys which already have a reduced function. In such cases, you may sometimes not be able to determine whether this is a high probability or not, and such cases are often labeled as intermediate probability for renovascular hypertension. So this is again another patient with bilateral renal artery stenosis, and you find on the baseline the right kidney is practically non-functioning, the left kidney is functioning well, and you can see that this is the normal functioning or a fairly preserved functioning left kidney, and this is the poor functioning right kidney. And post-captopril, you find both the kidneys have been are showing a flat renogram pattern. You can also look at segmental renal artery stenosis. So this is a patient. You can see this is a normal baseline study. You see the normal left kidney, the right kidney shows almost homogeneous kind of an uptake. And post-captopril, while the lower pole shows normal renal parenchymal transit, it is the upper pole which shows a reduced uptake, and which is often seen in segmental renal artery stenosis. I think this is more of the same thing. And this is a horseshoe kidney, and that kind of brings me to the end of this talk. So thank you very much. I see that the number of participants has diminished, but not so bad. So I'm very thankful to you for sparing all this time. I don't seem to be able to hear any of you. So if any of you have any questions or comments, please place them on the chat box, and I will try my best to answer them. So thank you. Somebody said, nice lecture, ma'am. In case you have, you have any thoughts on this later on, you're most welcome to contact me. My telephone number, I'm writing here. You can connect with me on WhatsApp, or you can connect with me on email. So if you have any doubts or anything, this is my email. So if you have any doubts or anything, or you want some images or something like that, please get in touch with me or with our the organizers, and we'll be happy to help you. So all the best to all of you, and I think I don't see any questions. So if you have any questions, please direct message them to me on WhatsApp, and I'll be happy to answer them. So thank you very much.
Thank you, ma'am. Thank you so much.